resident of Rajpura, having a short stay of 1 day in EM OPD. So our patient was a chronic alcoholic with alcohol consumption in serogeny doses for the last 25 years. In October 2021, he started having yellowish discoloration of eyes and pedal edema, for which he was evaluated at GMCH 32, where he was found to have transaminitis, hyperbilirubinemia, and on ultrasound a coarsened liver ecotexture with splenomegaly and mild ascites. He was diagnosed to be a case of decompensated cirrhosis, alcohol-related, which was managed with IV antibiotics, rifaximin, thiamine, and diuretics. He had clinical improvement over the next 2 days, after which he was discharged. In December 2021, prior to presenting to PGI, the patient started having shortness of breath, altered mental sensorium, and decreased urine output, for which he was admitted at a private hospital in Rajpura, where on evaluation he was found to have icterus, gross ascites. He was disoriented to time, place, and person. His urine culture showed E. coli, which was sensitive to meropenem and tryptase. He had transaminitis, OT more than PT, and hyperbilirubinemia. He was diagnosed to be a case of acute and chronic liver failure with grade 3 ascites, with grade 2 HE, with sepsis, with septic shock. The attendants took LAMA in view of no clinical improvement and logistical issues and presented to PGI with complaints of jaundice for 7 days, abdominal distension for 5 days, altered mental sensorium for 5 days, decreased urine output for 2 days, and shortness of breath for 2 days. The jaundice, which was present for 7 days, was in serious onset, progressive, associated with high color urine, but no symptoms suggestive of cholestatic jaundice. He also had abdominal distension for 5 days, which was symmetrical and insidious onset and progressive. He had altered mental sensorium in view of decreased responsiveness, which was insidious onset and progressive. He had decreased urine output amounting to 400 to 500 ml per day, which was associated with burning micturition, and it was not associated with hematuria or proteinuria. He had shortness of breath, which was associated with decreased urine output, orthopnea, and pedal edema. There was no history of fever, headache, blurring of vision, focal neurological deficits, and abnormal body movements. There was no history of trauma, and he did not have any constipation, hematemesis, or melena. He did not have any significant past history apart from the admission in October 2021 and any significant family history. But in his personal history, he was a chronic alcoholic, consuming alcohol in serogenic doses for the last 25 years, and his last alcohol intake was 7 days ago prior to presentation at PGI. He had decreased appetite and altered sleep-wake cycle. He also has increased frequency and burning micturition. On general physical examination, he had pallor, icterus, and pitting edema. His DCS was E2V1M4, following which he was intubated. His pulse rate was 100 per minute, but it was irregular and feeble. His blood pressure was 62 by 34 millimeters of mercury in right upper limb on a single inotrop. His respiratory rate was 28 per minute. His saturation was 33% on room air. On systemic examination, on per abdomen, he had a soft, non-tender, distended abdomen. His spleen and liver were not palpable. The fluid cell was present and bowel sounds were sluggish. On CNS evaluation, he had a poor GCS with bilateral pupils equal but sluggishly reactive. He had bilateral extensor plantars. The CVS and respiratory examination were unremarkable. On investigations, he had anemia, thrombocytopenia, and anemia and thrombocytopenia. He also had increased creatinine values fitting the definition of AKI. He had hypoalbuminemia, hyperbilirubinemia, transaminitis with OT more than PT, and an INR of 1.91. He had metabolic acidosis with a pH of 7.24. His ascitic fluid analysis showed high SAG, low protein with no SBP. His sepsis workup showed urine culture, which was done outside, to be positive for E. coli, which was sensitive to meropenem and tryptase, and his blood culture at PGI was sterile. The ultrasound abdomen done at PGI revealed changes of cirrhosis with portal hypertension with a enlarged spleen of 14.8 centimeters and moderate ascites. His echo, which was done on the same day, previous day, outside at the private hospital, revealed that he had a normal left ventricular ejection fraction and a non-dilated RARV. So, to sum it up, he was a 51-year-old male with past history of decompensated cirrhosis, now presenting with the above clinical features of yellowish discoloration of eyes and urine, abdominal distension, altered mental sensorium, decreased urine output, and shortness of breath. He was evaluated outside, diagnosed to be ACLF with ascites, with no SBB, with HE, with sepsis and septic shock. He was managed with IV antibiotics, meropenem and teicoplanin, Rifagat, IV thiamine and albumin infusion. The attendants took LAMA in view of clinical worsening and logistical issues on a single inotrope from that hospital with no oxygen support. He presented to PGI EMOPD at 2 p.m. In E2V1 M4 status with a BP of 60/34, following which he was intubated and the rate of non-RADR was increased. A diagnosis of ACLF was made, acute component being severe alcoholic hepatitis or sepsis, and the chronic component most likely being ethanol-related cirrhosis with HE grade 3 and shock requiring inotropic support. IV meropenem and teicoplanin were continued along with Rifagat and albumin infusion. Second inotrope was added at 10 p.m. in view of failure to maintain MAP on a single inotrope. He went into cardiac arrest at 11:50 p.m., after which CPR was initiated according to ACLS protocol. The patient could not be revived and declared dead at 12:18 a.m. So, in our clinical database, we have a chronic alcoholic with a past history of decompensated cirrhosis, having symptoms of jaundice, abdominal distension, altered mental sensorium, decreased urine output, and shortness of breath. He had pallor, icterus, pedal edema, poor GCS, and ascites on examination. On investigations, he had anemia, thrombocytopenia, transaminitis, hyperbilirubinemia, hypoalbuminemia, and a urine culture positive for E. coli. Ultrasound revealed cirrhosis with portal hypertension. So, in our discussion, we'll be discussing about the organ involvement in this patient, the basic disease, and the terminal event. The patient presented with above-mentioned features, which was suggestive of liver involvement and fitting the definition of acute and chronic liver failure. For acute and chronic liver failure, we have the following definitions. One according to PASL guidelines, then canonic study definition by EASL working group, the NACSL, that is North American Consortium for Study of End-Stage Liver Disease definition, and World Gastroenterology Organization working party definition. In APASL, it is usually used in patients with first decompensation, and the duration between the insult and liver failure is usually 4 weeks, less than 4 weeks, and the acute injury is liver injury only, and the organ failure is also considered as to the liver only. The severity is is defined by ARC score. In canonic definition, both compensated as well as decompensated cases are taken, and both hepatic as well as extrahepatic acute injuries can be there, and extrahepatic organ failures are also considered. The severity scores we'll discuss ahead. According to canonic definition, there is an acute decompensation with an organ failure with high 28-day mortality. The mortality rate increases with the number of organ failures. In our patient, we had ascites, the acute decompensation in the form of ascites, jaundice, and encephalopathy, and the organ failures were lung, circulation, and brain. For the chronic component, mostly it was alcoholic liver disease with chronic alcohol consumption and hepatomegaly with coarser negotiation with portal hypertension. For acute component, we can have sepsis, severe alcoholic hepatitis, drugs, acute viral hepatitis, and AIH flare. The first two components are most likely. For sepsis, we have a defined focus of sepsis in the form of positive urine culture. In alcoholic hepatitis, the patient fits the definition of alcoholic hepatitis short of a liver biopsy, and it is probable alcoholic hepatitis according to the definition. For brain involvement, we have the possibilities of hepatic encephalopathy, which is the most likely possibility. Other possibilities are septic encephalopathy, Wernicke's encephalopathy, SDH following trauma, CVA, and toxins. In circulation, we have the most likely possibility of septic shock, Cardiogenic and obstructive shocks can be ruled out because an echo was done the previous day at the outside hospital. The following articles reviews by Parcel reviews how bacterial infections are more common in decompensated cirrhosis. In renal involvement, the patient fits the definition of AKI, and it is most likely sepsis-related ATN. After clearing of sepsis only, we can define whether or not the patient has HRS. In
Terminal events, we come to terminal events. Terminal events.
Sir, in prognosis, we have the following scores: CLIPSI SOFA score, CLIPSI organ failure score, and CLIPSI ACLF score. Our patient has a mortality of mortality prediction of 52.3% 90-day mortality according to CLIPSI SOFA, and 64.4% mortality according to CLIPSI ACLF. These are the emerging therapies which are coming up, extracorporeal liver support systems, but the HELIOS trial and the RELIEF trial have not revealed much survival benefit. And in fecal microbiota transplantation is also underway, but the initial results do not show any, and the initial results do show improvement in short-term mortality. The GCSF trials have been done, which was done at our institute also, and the survival at 60 days is twice as that of the standard operator curve arm, and there is reduction in CTP, MELD, and SOFA score. Also, there is decreased risk of HE, HRS, and sepsis. So our final diagnosis is acute and chronic liver failure, with acute component being severe alcoholic hepatitis or sepsis, chronic component being ethanol-related cirrhosis, and organ failure of HE, grade 3, and circulation, most likely because of septic shock. Then the patient has had ascites with no SBP, AKI. He was a non-bleeder. The scores were discussed earlier, and a MELD score of 25 and CTP. The terminal event in this patient was most likely refractory septic shock.
Thank you, Tanusha. Now you can join me here.